Warm welcome to all the delegates and the teachers for this session. We are very happy to say that we are going to conduct the 8th episode of AKSHARAM series, which is a very famous and sought after webinar for all the, not only for the postgraduates, but all the young consultants and senior consultants. This is a combined program by Oxy Medical Education Committee and Foxy Medical Education Committee. Welcome to the episode number 8. We are actually going quite good. Next slide. I request our President, Vijaya ma'am, to give the welcome address.
Good evening, everyone. And I'm so happy to be for the another session of AKSHARAM. So every month we will think what all the topics not covered, and we will try to finish it off before April, March. That is what initially I planned. Actually, the past 7 episodes are really good, and it was so much knowledge sharing and very informative, and 2 hours for a single speaker, and she could cover almost whatever is there in that topic. And in that note, today we have our sweet Lily with us. And welcome all of you to AKSHARAM. And prolapse, we all know how much ever we study, we always have doubts. So all the PGs, if you have any doubts, please put it in the chat box and they'll be answered at the end of the session. Welcome again.
Now we'll start off with the lighting of the lamp. Thank you. Let this light brighten all our lives with knowledge and sharing. We always start our session with invocation, a song to the goddess Saraswati, the goddess of learning. Thank you. Now I request our Secretary Oxy, Dr. A. Geeta Lakshmi Madam, to give the Oxy prayer. Geeta Lakshmi Madam is Associate Professor at Government RSRM Medical Hospital and Stanley Medical College. She is an undergraduate and postgraduate teacher for many years, very dynamic Secretary of Oxy, and member of Chennai Menopausal Society, presented papers in various national and international conferences. And her areas of interest is high-risk pregnancy, adolescent health program, and medical education. Over to you, ma'am, for Oxy prayer.
Thank you, Karpagam, for the nice words. And it gives me an immense pleasure to welcome you all for this AKSHARAM series. And today we have an eminent teacher, Dr. Lily Verghese, a very good friend of mine from CMC Vellore, and she will be dealing with uterovaginal prolapse. So without the blessings of the Almighty, nothing is complete. So we will go on with the Oxy prayer. Thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch. to celebrate the arrival of each new life and mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are messengers to keep our women free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Thank you, Geeta Lakshmi ma'am.
Thank you.
Now, I request our President Madam to introduce Kiran Pandey Madam. She is a chairperson of Foxy Medical Education Committee. Ma'am, you're muted, ma'am. Vijaya ma'am.
I have great pleasure in welcoming my dear friend, Dr. Kiran Pandey. And now, in spite of she is out of the country, now she is in US. She is there for us in all our Aksharam webinar series, started from the beginning. And she's so much encouraging, and I get a lot of inspiration from Kiran. And he's a current chairperson of the Foxy Medical Education Committee. That made me join as a member in the Medical Education Committee because of her. And I got this input from her to take this Aksharam series in a very good manner. And she's got lots and lots of achievement. And she's a current president of Kanpur Menopausal Society. And lots of research activities and awards to her. Welcome, Kiran. I welcome Kiran to say a few words.
Yeah. I'm audible?
Yes, yes.
Yeah, thank you, Dr. Vijaya, for very, very kind words. It was actually the mutual admiration because I also loved your enthusiasm and specifically taking out very important subjects and the gem. You always take out the gem from an ocean and present it to our students. That's also a very, very important thing. So at the outset, I'm very thankful to our President, Dr. Jaideep Tank, Secretary General, Dr. Madhuri Patel, for allowing me to conduct these programs under the aegis of Medical Education Committee and together joining the Oxy Medical Education Committee with Vijaya. Today's topic, the pelvic floor dysfunction, is a very, very, daily, you see these problems every day, or but still even in the modern obstetrics, still it is seen. And if not, the percentage incidence might have decreased, but actually pelvic floor dysfunction is still playing its important role, and one has to understand this because the one important part of the examination also, one or other student will have it. So I welcome our learned speaker, Professor Lily Verghese. She is a professor at HOD Obsgynae Vellore, and at this moment I just want one request also to make, and it just came to my mind when I talked that if she's interested in coming to Kanpur Menopause Society, we are having a Urogynae workshop on 21st of February. And there is this pelvic floor dysfunction is an important part. And considering Vijaya has selected you as one of the most important person, I'm sure you will turn out to be the best for this to every delegate. So if you by any chance have this time and date free, it is again, I'll say 21st of February 2025. So I would welcome you there with all love and affection. We welcome every candidate. In fact, I requested Vijaya also, but she also have a family commitment. But you have suggested Meera Raghavan. Meera is also coming and going to do a panel into that. So thanks to you, Oxy, and Kirpa, and Dr. Geeta, Dr. Vijaya, and our learned speaker, and all the best to our students. Today I'm a little busy. I might not be able to continually join it, but I know the importance of subject and very few importance. It appears to be a very simple, but it has its own important points which one has to understand when dealing in life and the permanent. Otherwise, we have seen it, if not properly dealt with it, what are the results and the women suffering from it, for they are very much important. So thank you. With these words, I wish again everyone all the best. And again, I welcome you all, Dr. Geeta also. If any, I mean, all those who are interested, we are really keen to have you all at Kanpur.
Thank you. Thank you,
Thank you
Kiran,
very
for
much.
this lovely words.
Thank you, ma'am. Thank you. Now, we'll go on to the teaching session. Now, I request our President Vijaya ma'am to introduce the teacher.
Well, Lily is my best friend, and I know her for so many years. Ever since she came as a specialty training with Rajamageshwari ma'am and in Government Kasturba Gandhi Hospital, Triplicane, and she used to stand out among all the crowds. So I went and spoke to her and made friend with her. That's how it happened. Actually, I didn't know her personally. Only when she came as a trainee to Rajamageshwari ma'am, and all the theaters and all, we used to smile at each other. Slowly became very close, and ever since we are very good friends. And you all know always the tag that matters, and she is from Christian Medical College, Vellore, and we all look up. Whoever is from AIMS or CMC, that tag is always there with us, and of course from MMC IOG also. And she's a professor, head of the department of OG, and she's the head of the unit of urogynecology and OG2. And she has done her master's, and she's certified urogynecology from KGH MMC Chennai in 2009. And she's an observer fellowship in Loyola University Medical Center, Chicago, 2007. She is a fistula surgeon from 2016, Freedom from Fistula Foundation, West Africa. And areas of interest, of course, what else it can be? Pelvic floor reconstruction, female congenital genitourinary anomalies, very, very important, the reconstruction, and minimally invasive gynec surgery, as we all do, lab, an undergraduate and postgraduate teacher, a very good teacher, examiner, reviewer, and lots of publications, international and national journals. Welcome, Lily, the most beautiful and very smiling Lily, to this session.
Thank you so much, Dr. Vijay. It's always a pleasure to touch home base with my MMC colleagues. Thank you very much, Dr. Vijaya, Dr. Geeta Lakshmi, Karpagambal, office bearers of the medical education cell, both OGC, FOGC, particularly Kiran ma'am. Thank you very much for your invitation. I will surely keep in touch. And I cannot tell you how overwhelmed I am to be, in a way, speaking back with my alma mater and all my colleagues across Tamil Nadu, and I hope even beyond. So thank you very much, ma'am. Shall we start with the talk? Shall I share screen?
Yeah.
So this is a very, very important topic, as Kiran ma'am said, pelvic floor dysfunction. But we have a few problems with this concept of ours. We think of pelvic floor dysfunction as only pelvic organ prolapse. Okay, without much ado, I'd like to tell you that pelvic floor prolapse is only one segment of it. Okay, so because the pelvic floor is a very extremely important structure, and we many times fail to understand its importance. 1 minute. I hope you can see my slides.
Yes, ma'am. Yeah.
Okay, so we fail to understand its importance. So just 2 or 3 slides on what we think it is. So most of us imagine it like this first picture, like a flat piece of muscle, and we think of it as only the levator ani when we talk pelvic floor. Then some of us with a little more advanced understanding think of it from the perineal view like this. Okay, so we see all these structures, and when we do more advanced surgery, particularly gynecological, oncological surgery in the vulva, genital anomalies, etc., we understand it. Then many of us slowly come to the understanding that it is the super bowl of the pelvis. It's a bowl-shaped structure that literally holds up a lot of things alongside with it, and it's not just a flat muscle. Now, in spite of understanding all that, our understanding is still defective because it's a very, very complex web of muscle, fascia, and fibrous tissue, which is under both neurological and humoral control. So, if any one of these segments go wrong or out of sync, we fail to get the function and the integrated action that we expect.
So it's very important to understand that these are not just isolated muscles. They are linked to fascia, to bone, to fibrous tissue, and the quality of this also matters. So as I was talking to Dr. Vijaya, she told me, I told her, my goodness, pelvic floor function, dysfunction is so much, as you can see from this diagram. How do we cover this? Because it's literally the whole of urogynecology. She told me speak mainly on prolapse. And I said, okay, since PGs are attending, we'll speak mainly on prolapse. However, what I'd like to get across here is each and every one of this requires a whole 2 hours in itself. So at first, I'd like you to appreciate the fact that the pelvic floor is a segment or is at the bottom of the abdominal cavity. Okay, or the levator ani. So the whole pelvic floor is integrated to the abdominal and the trunk, the back muscles, and through it even to the diaphragm. It even supports breathing function, posture. All these things are extremely important. Though we talk about pelvic organ support, mainly bowel and bladder control, I would like to say that a very, very important factor is sexual function, because this is very, very underrepresented and usually affected by pregnancy and childbirth. Okay, so having said that, let's go to the outline of the class. I would like to predominantly talk about pelvic organ prolapse today on these various things, on these various aspects about staging and option management. However, I'll be touching very briefly on urinary incontinence and fecal incontinence. I'm not talking about sexual function, the effect of childbirth and pregnancy, etc. They are huge topics in itself. Okay, so looking back at this, you can see how the pelvic floor by its attachments is perfectly suspended to various structures of the body, both anteriorly, posterior, and laterally, forming a bowl shape which is able to provide dynamic support to all these structures. Why is this dynamic support, which adjusts itself minute by minute, important? Because through the neurological and humoral control, this is what keeps the organs in space and allows for complex physiological function. Now, D. Lancy, now being PG level, now these are all questions that come. D. Lancy divided the supports of the vagina. Okay, so once I had an undergraduate who came and asked me, ma'am, is it pelvic organ support? Did D. Lancy divide it as pelvic organ support? Did he divide it as uterine support? Is it a uterine support? Or is it a vaginal support? So I told him, look, it's mainly vaginal support. However, by supporting the vagina, it ends up supporting all these other structures. So D. Lancy, to make this clearer, though we often understand, we fail to understand its significance because we have not classified it in our head. So D. Lancy undertook this task and he called level 1 the cardinal uterosacral complex. So it is fused at its attachment to the uterus and it literally holds up the cervix and the upper vagina, the vault particularly, by suspending it by the transverse cervicals to the lateral abdominal, to the lateral pelvic wall, and by the uterosacrals to the sacrum, the uterosacrals, and it's also connected to the cervix in front. So through all these structures, it provides a firm stability at the upper level of the vagina because it has to work against gravity. Now at the lower level is another extremely important structure, the perineal body, the perineal membrane, etc., which again fixes it across the opening, across the bony pelvis. Between these two relatively fixed points come the midsection of the vagina, which has to distend and collapse during its various physiological functions. So this segment of the vagina, the middle portion, which we call the level 2 supports, are connected laterally to the arcus tendinous fascia pelvis or the white line, which is a thickening across the obturator internus. So it literally holds the vagina back like this. And it supports by its attachments to the rectovaginal fascia behind and the pubovesicocervical fascia in front. It provides a complete envelope of support which holds up the vagina and by its attachments help to also support the bladder and urethra in front and the rectum and the anal canal behind. So level 1 and level 2 are relatively fixed structures with the mobile structures in between, which allow for distension, collapsing, but also provide dynamic support. So these levels of support, understanding these levels of support helps us to also understand the various defects we see. So as I already said, the proximal or level 1 support involves these very important strong ligaments, the uterosacral and the cardinal. And a defect in this level 1 support or at the apex results in uterovaginal prolapse, vault prolapse, and enterocele, all which come in at the apex, at the very top. Mid-level support, when it is lost, okay, results in anterior and posterior vaginal defects and stress urinary incontinence, which is usually spoken of as the cystocele and the rectocele. And distal vaginal defects or the level 3 defects, okay, when the introitus particularly is widened, results in a lax perineum. It can result in a low rectocele, anal incontinence, and sexual dysfunction. Okay, so why is this so important? Because it is likened to a suspension bridge where all the structures are held up by ligaments like ropes. Okay, there's also an analogy to a boat in a dry dock. So why did I put up this picture at the side? Because when you look at it, you realize how this is the urethra, the vagina, the external anal sphincter, and the rectum. You realize how through a series of muscles and ligamentous attachments, they work like various slings supporting by opposite forces one another. We will develop this further. The analogy often given is about a boat in a dry dock. What does this mean? When a boat is suspended well in the water, it is sailing in, there's a buoyancy, the boat is able to move, it is also supported. So even if it is tied in a dock by ropes, the ropes are not under strain because the buoyancy of the water below. Now the water below is likened to the pelvic floor. The ropes are the ligaments which hold the uterus and the pelvic organs, which is the ship, in place. So the minute the pelvic floor weakens, or if you take away the water, the buoyancy is lost and it starts sinking. As it progressively sinks, it strains the ligaments and ligaments develop stretch, tear, and after it reaches a point, there's a total loss in function. So this is very important to remember. The second thing I want to focus on, especially for the postgraduates, is the nomenclature. We do not call it uterovaginal prolapse because it's not just the uterus and the vagina, but it's also the bladder and the urethra which can get dragged down as this picture shows, and also the rectum, the anal canal, and the perineal body. Hence, all the pelvic organs are involved, and therefore it's called a pelvic organ prolapse. Now, what causes it? Though this sounds extremely basic, this is all for the benefit of our postgraduates. I know many of you do not need all this. However, there are multiple factors given, and very often we are quite, confused. Oh, is it collagen weakness, obesity? And I often hear any question you ask, genetic factor, okay, Marfan syndrome. Now, how common is Marfan's? Very uncommon. However, though we may not be Marfanoid, many of us, particularly the undernourished people who are vaginally multiparous, with aging and loss of tissue support because the estrogen is withdrawn, because of all these various factors, what happens is a overall loss of collagen and a weakness of the collagen, which results in pelvic organ support. But if I would pick the main three, I would say pregnancy by itself, and of course parturition. Okay, mainly vaginal delivery can result in direct trauma to the pelvic soft tissues, cause it to overstretch. And once it goes beyond a limit, it stretches more than 3 times its length, it can result in permanent tearing and weakness. Now, vaginal delivery, as I keep on saying, is the main culprit because it's a large head that's passing through the canal and it's distending and stretching and tearing tissues as it comes out. Of course, we often do not realize that repeated pelvic surgeries can also cause injury and de-innervation, though we do not see these fine nerves. It is important in the maintenance of pelvic support. And of course, the final straw that breaks the camel's back is menopause. when the hormonal support is withdrawn and all the potential weaknesses in the pelvic floor are shown up. Bump et al., who was very important in the classification of the POPQ system, divided all these various factors that we speak about. They classified these factors as predisposing, which is mainly your race, your genetic component, and of course the female more than the male. The inciting factors, which is a very good way of thinking. This classification is very good. Okay, surgeries even such as hysterectomy, pregnancy and delivery, you can see takes pride of place here. Promoting factors, our lifestyle, the various diseases we have, and what ultimately causes decompensation is aging, menopause, and other debilitating neuromuscular diseases. So, what are the signs and symptoms we see? How do we classify this? What I would say is the signs and the symptoms depends upon the anatomical level of support affected and the organ behind the prolapse. So which compartment? So if you talk about the supports are mainly divided into 3 compartments. I'm sorry for the poor quality of this picture. So if you look at it, how it is color coded, and we look at a sagittal section, it is divided as an anterior component, which involves the bladder and the urethra, the mid component, which is the uterus, the vagina, and the uppermost portion of the posterior fornix, etc., with the bowel, and the posterior component, which involves mainly the rectum and the anal canal with the perineal body. If we keep these 3 compartments in our mind, it is very easy to understand because you can see different kinds of prolapses, and you occasionally see a prolapse looking just like this long protuberant cylinder. This is mainly when there's a loss of apical support and there is no loss of level 2 support, but the whole thing sinks and drags the other organs around with it. On the other hand, this is a very different kind of prolapse. You see there's a perineal body, but there's a bulge coming out of the vagina mainly from the posterior wall. This is a level 2 support defect. And when you look at the level 3, when there's a loss of the perineal body or an obstetric anal sphincter injury, what you would see is a wide gaping of the introitus, particularly a loss of fecal continence. And of course, let us not forget sexual dissatisfaction by the partner. The normal classification is an anatomical classification, is a traditional classification. Let us not put away tradition because it does give us a very good idea of what lies behind. However, we modify this. So when you reduce a prolapse, this used to be a great point of confusion for me as an undergraduate because what I am seeing at the lowest point is described in the textbooks as the highest point. So I see the cervix protuberant, and I see the cystocele next to it, but I am told this is the upper 2/3. What does that mean? When we reduce a prolapse to its original position, and we hold the uterus in its position and then we ask the patient to bear down. If we see a bulge in the upper 2/3 of the vaginal wall, it's usually a prolapse of the base of the bladder into the vagina. A lower 1/3 is the urethra, and if you have both these which are defective, it's a cystourethroceal. What eventually happens in an anterior vaginal prolapse is the urethra is usually well supported by pubourethral ligaments. So the base of the bladder, as you can see, just has the vagina to support it. This progressively herniates into the vaginal canal and then outside, leading to kinking at the bladder neck. When this happens, which is stage 2 or more, the woman starts becoming symptomatic. So it's important to remember that mild degrees of laxity, mild degrees of prolapse, what we call stage 1, are not really significant and should not be considered as significant prolapse. A woman becomes symptomatic only when she reaches stage 2 or more. So, when we look at the posterior vaginal wall, again what we find when we compare to the normal anatomy, you will realize that though the rectum comes in contact with the mid-vagina, it deflects away and the external anal sphincter, that is the perineal body, separates it from the vagina. So when we find the rectum in close apposition, either prolapsing into the vagina outside it, there is invariably a loss of the strength of the perineal body, which is a level 3 support defect. Now, if you find a bulge involving the upper 1/3, I would like you to look at this picture. It is usually the bowel which has come into the pouch of Douglas and herniated. All it looks is like a bulge that has herniated into the vagina. So that's an enterocele. While a rectocele typically looks like this. There is a middle or of the posterior vaginal wall which looks deficient, and it is usually associated with the attenuated perineum. So now as we continue with this, what do we see? Okay, an attenuated perineum in the lower 1/3. Very often we fail to recognize the importance of an attenuated perineum. However, this is increasingly recognized to be important to stabilize and prevent prolapse from occurring from the middle thirds of the vagina, both anterior and posterior, by providing strong support against these prolapsing segments. So what exactly is a post-hysterectomy vault prolapse? This is another term where usually after hysterectomy, the upper portion of the vagina descends. Down, it is as like a sort of an intersusception. It sort of folds in on itself. And this very often is a result of a failure to close off or to recreate the pericervical ring. The tissues which are condensed around the cervix are not approximated adequately. So if you take only the vaginal edges and approximate it, there is a gap there, and through this bowel loops can herniate. Very often it's also the bladder. So when you have a post-hysterectomy vault prolapse, it can very often, when you see a bulge, you cannot be sure which organ is behind it. So one has to be very careful when we classify it as a cystocele or a enterocele. You need additional examination. Now this term procedentia was very, very popular in the past. So when you say, what do you mean by procedentia? When you say procedentia, when we were all studying, we said, oh, the vagina is totally everted. And all of you in the government hospital setup would have seen large prolapses or even larger prolapses than this. And what you will see is you are able to get above the swelling. What does that mean? When you put two fingers, this is an important test. You can feel the fundus below your fingers, and you can feel both your fingers approximating. Now, this is a procedentia, and it's always an advanced stage 4 grade of prolapse. Now, very important, as you look at this picture, you can see an ulcer here. You can see a dark patch here, which is keratinization. And you can see another healing ulcers. These are decubitus ulcers and keratinization, which denote long-standing prolapse with venous congestion. Okay, so prolapses are of various kinds. You may just see a bulge outside the vagina like this as the patient does a Valsalva. You may see a small cervix sticking out like this with a bulge anteriorly and posteriorly. And here very clearly the external anal sphincter and the perineal body is seen. Or you may see just a mass like this with a lot of ulcers. Now, how do we go about comparing these different kind of prolapses? Because they contain very different segments. They have a different level of severity. And so we come back to the area where we call it anterior urinary symptoms. So we see how severe the symptoms are. And I would like to reiterate that symptoms usually occur at stage 2 or more. So if you divide this into the anterior, middle, and posterior segments, you will basically be dealing with urinary symptoms in the anterior segments, which can involve a host of symptoms. Because of the laxity, initially the woman has stress urinary incontinence. She coughs and she leaks urine. As this worsens, the prolapse worsens, there's kinking at the bladder neck, and she's unable to void completely. This can lead to a urinary tract infection and urgency, and this can also lead to changes in the upper tract. This decreased urinary flow is a typical history when there is kinking, and it may actually mask a stress urinary incontinence, which is called occult urinary incontinence. And there is difficulty in initiating, and because of incomplete voiding, the woman herself may use her fingers to push back this mass. Instinctively, she understands it. And this is called digitation or splinting. It's like you have a mass, you push it up and you literally keep it splinted in place in order to be able to pass. This is just like the orthopedic concept of putting a splint. So when you splint it, it is definitely a more advanced grade of prolapse, and you will never need splinting in a lesser grade of prolapse. That's a very important thing. So every postgraduate should talk about whether the person needs to splint or to change position and able to void. That would tell you instinctively that it is definitely more than a stage 2 prolapse. So what is involved in the middle segment? Middle segment is mainly the mass protruding out, causing mechanical discomfort. In the initial stages, there's a stretching of the ligaments, so it leads to low backache, especially later in the day. And because of this mass lying outside constantly, there's decreased venous return leading to ulceration, which in its own way can lead to pain, can lead to secondary infection causing bleeding, and an increased vaginal discharge. So middle segment symptoms include all the mechanical effects that you can find, while the posterior segment involving mainly bowel are very similar to the anterior segment symptoms of urinary symptoms, but usually of lesser severity than the anterior segment. Very occasionally, the woman may tell you that she may have to digitally evacuate by putting her finger into the rectum, because what happens is as the rectocele protrudes outside, literally like this picture. Wait, I will show you this picture. What happens is as the feces comes in, it sits and gets into a pocket and becomes hardened stool. And then the woman constantly feels a sense of irritation and incomplete evacuation. And sometimes she literally has to do a per rectal examination on herself and digitally evacuate the feces. This all tells you that there is a significant problem there. However, last on this list are sexual symptoms, which the patient very often does not mention, which the doctor very often does not ask. But remember, sexual symptoms can have a major impact on the quality of life, particularly during intercourse. A woman can have urinary or fecal incontinence, which may cause her to avoid intercourse, and it may create problems in the relationship. Or she may even have inability to have intercourse due to the mass. So if you ask her, are you sexually active? She'll tell you no. But the next question everybody should ask is, would you like to resume sexual activity if I repair this? Now, why is this single question so important? Because when you are treating a prolapse, particularly surgically, the length of the vagina, the width of it, its caliber, and the introitus matters. So if you make it too tight, this will become impossible, and the woman is very often unable to vocalize this. On examination, I'm going extremely briefly through this because there's a lot involved. So we look at a gaping introitus. That's the first thing that we see. And through this gaping introitus, when we ask them to strain, you usually see the mass. You also note not just the gaping introitus, but you look at the genitalia as a whole. See whether it is consistent with menopause. See whether there are local infections, any other causes. Okay, so look at the gaping introitus, that the mass that's protruding through. Look for perineal scars and look particularly at the perineal body and the external anal sphincter. All this should be documented. Then you may see a visible just an anterior vaginal bulge or a posterior vaginal bulge. But very often the cervix is seen as the leading portion. So as a postgraduate, you don't need to say pink mass with an opening in the center. All you need to say is the cervix is protruding out and I can see a bulge on the anterior wall and the posterior wall. You do not need to qualify what is behind the bulge. Okay, so also look at the cervix to see if there's ulceration due to friction and due to contact, which is called a decubitus ulcer. You may look at it just by inspection. You can tell whether this is a major degree of prolapse or not. But for checking and telling whether there's associated pathology, one often needs to do a digital pelvic examination. Of course, take note of the comorbidities. Now, why do I like this picture? I'm sorry, it does look a little faded out. As you can see, a purse speculum and a digital pelvic examination are important. This brings us to the grading or the staging of pelvic organ prolapse. Okay, so you see a uterus sitting right on top when it's well supported. You see the hymenal ring being shown here. Then there's an arrow showing the introitus. Now, in the older classifications, like the Baden-Walker's halfway system, which is very popular even today, which should no longer be used, the introitus is used as the reference plane. When you use the introitus in a very chubby woman, the introitus may be way, way ahead of the hymen. And so if you say a prolapse is present at the introitus, it may not be the same as a prolapse in a thinner woman. So the pelvic organ prolapse, as you can see, 1963, 72, 1980. In 1996, the quantitative pelvic organ prolapse or the POPQ system was adopted. Why is this important? To compare outcomes measured quantitatively. The operative word is quantitative. So you are measuring it in numbers. You are giving a quantity to it, and that is usually in centimeters. So you take these numbers and you compare prolapse, particularly when you're doing research. Because very often, as I will go back and show you, this prolapse, which may look very large to a PG who saw not seen much, is very different from this kind of a prolapse. Okay, and when you say, oh, this is halfway out, okay, stage 2, stage 3, in the POPQ system, it makes a big difference. So while this may be stage 2, this is stage 3, and definitely this is stage 4. And the post-repair outcomes may be very different in these different kinds of prolapse. Forgive me for changing this. So what is the most popular system is known as the Baden-Walker's halfway classification system. I'm touching upon this because this is what you are all instinctively using. Now the cervix or the cuff is usually at the level of the ischial spines. When the prolapse, this is the normal position of the cervix. When the prolapse descends into the vagina, halfway up to the hymen, this is called stage 1. When it descends up to the introitus, the old term used was introitus, it is stage 2. And when it descends halfway outside, it is stage 3, and maximum descent of procedentia stage 4. Now, each organ is classified as grade 1, grade 2, grade 3, grade 4 based on this. Halfway in the vagina, up to the introitus, halfway out, and fully out. However, this does not convey the severity of the prolapse, as I told you. And when we convey it in centimeters, one gets a better idea of how one can compare our own results on different stages of prolapses and also how two different observers or surgeons can compare their results. So the POPQ system is very important, and the hymen being the reference plane, as I'm showing you here, this is a case which we are operating. So you can see the hymen is very well demarcated all along the posterior aspect. The anterior aspect corresponds to the external urinary meatus. So one can, if you are examining, you can measure the bulge either from the external urinary meatus or the hymenal remnant. So this is your reference plane. When you use this as a reference plane, we measure 2 points anteriorly, which is one is point A anterior, AA, which is a point 3 centimeters from the hymen in the midline, 3 centimeters, it's a measured point. It usually corresponds to the UV fold. And similarly, there's a point posteriorly. As we go above this, the most significant point is point C, which one cannot miss, which represents the cervix. So imagine you're going from inside and you're looking up. That would be like this, like a cup shape. There are 2 points anteriorly. The lowest point between point AA and C anteriorly is called point BA. Then you have point C, which is the cuff in the post-hysterectomy case or the leading point of the cervix in a woman who has a uterus in situ. Then point D, as you can see, is the point of attachment of the uterus sacrals. And then there's a point B, which is the most dependent on the lowermost portion posteriorly on the posterior vaginal wall, and point AP. So if you look at it like this, there are 2 points anteriorly, 2 points at the vault, which is cervix and fornix, and then 2 points posteriorly. Very simple. Then there are 3 points in between in the 3 by 3 grid, which is not measured by positive or negative signs, and this is the genital hiatus, the perineal body, and the total vaginal length. So if you just imagine you're looking inside a vagina, there are 2 points anteriorly, 2 at the vault, 2 posteriorly, and 3 points in between, which tells you other parameters which you should look at to document support defects. Okay, so this is one of the pictures which I hope will make it clear to you as to how to do a POPQ. Usually the woman is doing a Valsalva and is conscious. However, here this is a case on table to clearly demonstrate it. As you can see, we are giving traction with the valsalva. And the leading point of the cervix from the hymenal edge is measured and documented as point C. Similarly, the point D, which creates the maximum confusion, is the point of attachment where the cervix and the vagina meet. This is also the point where the uterosacrals are joined to the supravaginal portion of the cervix. And this is also the point of the posterior fornix when the uterus is reduced back into its original position. So you mark this point and bring the prolapse outside and ask the woman, and you measure it from the hymen. So point D should cause no confusion. If you remember pouch of Douglas, D for Douglas, D for the point of attachment of the uterosacrals. I hope this makes it clear. We do not have time to go into it. However, I'd be very happy to even do a workshop if any one of you called me for one of these things. We can do a live workshop. It would be very, very interesting. So the POPQ numbers are taken and it is documented as an ordinal stage. As you can see here, stage 1 is where it is just telescoped into the vagina and not really considered to be a major problem, but you can see how it's pulling the vagina with it. Stage 2, when it is +1 to -1 centimeters as measured from the hymen. Stage 3 is when it's a little more outside. And stage 4 is when there is a total vaginal eversion. Now, what about the treatments for pelvic organ prolapse? Pelvic organ prolapse does not always have to be equal to surgery. In fact, the preventive aspect is very, very important. Even as a woman is pregnant, we can explain to her as to how to do pelvic floor exercises, how to avoid constipation. Okay, and all these factors can reduce subsequent pelvic floor dysfunction. Okay, so these include lifestyle interventions, avoiding obesity. Okay, so all these come under lifestyle interventions, while the pelvic floor muscle therapy or the so-called Kegels exercises help to keep the levator ani active and well developed to prevent the pressures transmitting from the upper vagina down into the lower vagina. The levator, strong levator ani, also maintains the posterior axis of the vagina, which promotes anteversion of the uterus and closes off. It becomes almost horizontal and closes off the vagina during times of increased intra-abdominal pressure. So a pelvic floor exercise, to put it in brief, can be done by all ages, can be done by all women. It can be done by women who have good anatomy. It also improves sexual satisfaction. It can also be done by women who have prolapse and who are slated for surgery because it helps them subsequently to maintain pelvic organ supports. And it can also be done by women who have mild stages of prolapse to help them prevent further aggravation. So, of course, when in women who have urinary symptoms, bladder training, avoiding bladder irritants, timed voiding, the correct amount of fluid to drink should be told. Electrical stimulation has been used by various people to help the pelvic floor to contract and for us to recognize the pelvic floor. There are various methods, behavioral strategies, of course, how you would bend, how you would pick up a weight, how you can hold your pelvic floor before you lift a heavy weight is very important. And of course, the first line of management as recommended is a vaginal pessary. Now, for a vaginal pessary to stay in place, as you can see the position, it should not be too large such that it kinks the bladder neck and prevents voiding, nor should it be too small that it slips out. So it's important to measure how large a pessary can be used. It's important to use a silicone pessary to prevent pressure on the walls, and also important in a postmenopausal woman to use some kind of a local vaginal cream to allow for a thickening of the vagina. Now, what is the most important factor in a pessary treatment is the strength of your pelvic floor. If your pelvic floor is weak, the pessary will not hold in place. Also very important is a pessary can only be used by a woman who's agile enough to take it out, clean it, and put it back. Now, what happens if a woman is not conscious? She's much older person who's not agile, who's not flexible. Her caretaker can do it if they're willing. And either the woman or a caretaker has to be taught how to use the pessary, how to remove it, how to wash it, and how to take care of it and replace it. These women should intermittently be called into a clinic to make sure the vagina is not getting ulcerated and the pessary is not getting incarcerated. We had a very interesting case many years back where one of my PGs actually wrote it up, where the red Bengali bangle which married women wear was used as a pessary and was so incarcerated that it had vaginal epithelium growing over it. So we had to actually give anesthesia and cut through the vaginal epithelium to release this bangle. So such hard bangles should not be used. What should you should be using is a silicone pessary. So it is ideally used to decrease the frequency and the severity of symptoms, or to delay or avoid surgery. So if a woman says she has a son's wedding to attend to, or she has an important conference coming up, and she cannot come for a surgery, and she wants this reduced, or there's a decubitus ulcer which needs healing, a pessary is an excellent method. However, word of warning, kindly do not use plastic bangles, hard metal bangles, stones, seeds, which can be fruit seeds, which can be placed inside and which used to be placed in the past. It can lead to severe incarceration and infection. So what is the surgical treatment? A word of warning. At first, a surgical treatment should only be considered in a woman who has a symptomatic pelvic organ prolapse. It should never be done just because you see a bulge. Now, the aim is to restore anatomy by correcting the defect. So there's a defect. You anatomically try to correct it, the defect, such that this organ can work functionally, or there's a physiological cure. So your anatomy is not divorced from physiology. The whole point of you correcting anatomy and the pelvic floor defect is to provide a cure or improvement by improving her symptoms, by providing functional recovery. And so that's the whole important point. The proof of the pudding, we often hear the saying, is in the eating. So when you know how good, so like on MasterChef, somebody cooks something, it looks beautiful. But when you put it into your mouth, it doesn't taste good. So what do? They would score a dish which is cooked higher, which tastes good and which is good to the tongue, rather than something which looks good. So I would advise you to use the same principle as MasterChef. No matter how perfect your surgery is, if that vagina is not restored to a functional capacity, if it does not restore urinary or bowel symptoms, this vagina is of no use, because I think we can all agree that the vagina needs to be a functional organ, not something which looks good, because nobody is really looking at the vagina to appreciate it by itself. I bet you all agree with that. Okay, so the treatment options, the risk, your patient is a co-partner in this decision. So you cannot make a decision. You cannot say, oh, I will do surgery for her. Counsel her, discuss with her, and then undertake the treatment options. Discuss the risk, benefits, and the outcomes, particularly keeping an eye on functional recovery. So the types of prolapse surgery can either be restorative or obliterative. By restorative, what do we mean? We are restoring either bowel, bladder, or sexual or fertile function, fertility. One of these functions or all of these functions have to be restored. On the other hand, opposed to it is obliterative surgery, which closes off the vagina And though it may restore bowel and bladder function, prevents sexual function, and prevents a restoration of fertility. So restorative surgeries are many, are very confusing when you read the book. However, remember that restorative surgeries are mainly vaginal. It can either be a hysterectomy if you want to restore menstrual or fertility function, or you can do a hysterectomy if these two functions are not required. It is usually accompanied by a facial repair, which is an anterior and a posterior repair. Or if these repairs are not possible, or you are doing a recurrent surgery, one may choose to augment it with the synthetic mesh, an autologous mesh, a donor mesh, or a xenograft, which is a mesh like a bovine mesh derived from an animal or a porcine graft. Now, one has to also take the person's religious sensibilities into account when we are using these different kind of grafts. And this has to be discussed with the patient, which is why I tell you, your patient is a co-partner in the kind of surgery you would offer to her. Now, very often with all these, what we call native tissue repairs, is usually restoring support. And if the support is lost at level 1, one has to offer the person an apical suspension procedure. What does it mean? The word itself explains it. You have to suspend the apex. That means you restore level 1 support. And this is usually done by taking the vault and attaching it to either the sacrospinous ligament, attaching it to the uterosacral ligaments, which can be done as a low repair, which is called a McCall's, or a high repair, which is called a high uterosacral ligament suspension. Or you can do a iliococcygeus suspension by fixing it to the pelvic muscle. But this is usually provides less sustainable results and is usually done in a very short vagina as a salvage procedure. Now, the operations or restorative operations can also be done abdominally. It can be done either by a minimally invasive procedure like a laparoscope or a robotic procedure. And it can be done either through the peritoneum, a transperitoneal, or you can do it in the space of Retzius. Now, it all depends upon the skill of the surgeon. You can do it. So, to repeat myself, the surgeries are mainly done vaginally. The surgeries always may include a hysterectomy or a hysterectomy along with the facial repairs of the pelvic tissue. So you may choose to do this abdominally, and abdominally it is mainly done for a paravaginal repair in a cystocele, and it is done in a hysterectomy. And it is usually the points of attachment, it is reinforced with the mesh when done abdominally and reinforced to the sacrum or to the uterosacral ligament. Minimally invasive surgeries are just an extension of the open abdominal procedures. Now, the mainstay of treatment is a vaginal surgery, and that usually involves a vaginal hysterectomy, particularly in our context. Though the Western context may tell you there's no need to do a hysterectomy, invariably we have women who are lost to follow-up, women who are poorer, women who do not understand that you may have postmenopausal bleeding. So we do not, as a rule, preserve the uterus. If it is a woman who does request, can you preserve my uterus, who is highly educated, who is very particular, even after the function is complete, please do so. But provide adequate supports at level 1, 2, and 3. That should be the gist of your treatment. Now, very often when we do a hysterectomy, we are left with an open vault. And the first procedure we should provide with every woman is a McCall's scaldoplasty. What does that involve? Taking a suture into the uterosacral ligament, closing off the redundant enteroceal sac, or going as high above until you see the fat of the rectum, taking sutures to the other side and closing it off. Now, as you see in this picture, you may simultaneously exteriorize the suture before you come to the other side, which is called a external McCall's. On the other hand, if you look at this picture, you see the purple thread, which just goes from uterosacral to uterosacral. This is called an internal McCall's. Now here you can see after the suture is taken and tied, it's exteriorized. This is again an external McCall. So there are various ways to do a McCall scaldoplasty. But essentially, it has to be done in every case because an unrecognized enterocoel is the cause for a vault prolapse. The main repairs, what we all see and understand, is a cystocele repair. And this kind of a cystocele is usually called a central cystocele. What do you mean by central cystocele? The pubovesicocervical fascia is thinned out and you see a diffuse bulge into the vagina. And so the repair is initiated by opening up the anterior vaginal wall, by opening up adequately, very often up to the bladder neck, by dissecting the fascia of the underlying vaginal epithelium, and then using reinforcing sutures, which are either polyglactin or PDS, to close the fascia to reduce the prolapse, which is, it can be done in one layer, it can be done in multiple layers, and this is called a native tissue repair. This usually goes by the name of anterior colporrhaphy. However, there's another kind of repair on the anterior vaginal wall. So if you look at the pubovesicocervical fascia, this is, you are looking at it from inside the abdomen. If you look at it in the space of Retzius and you are looking at it, this is the pubic symphysis, you realize the bladder is actually lying on a sheet of fascia, which is very often called the pubocervical fascia. So it is attached from the pubis to the cervix of the uterus. So this is a sheet which goes on to attach to the cervix at its cephalad aspect. The bladder lies on this. So when it is stretched during delivery, sometimes instead of a diffuse distension, you can have discrete tears which tears it off its lateral attachments at the white line of the pelvis. So what happens is when this woman coughs or strains, this bladder may go through this defect and herniate. So it is a discrete tear. This is called a paravaginal loss of support or a paravaginal hernia. So it's not a distension, it's called a displacement cystocele. Why is it called displacement? Because these attachments have broken off as this picture shows and that side of the vagina sags. How does one recognize this? When you see the loss of this head-shaped structure of the vagina, and if you put a ring forceps and lift it up, you will see that the prolapse actually disappears. Now look at this beautiful picture to the left of my screen. Okay, it shows you the normal support of the vagina, how this pubovesicocervical fascia is attached from the pubic symphysis, sits under the base of the bladder and is attached to the cervix on top, and then attached like a trapezoid sheet to the lateral vaginal wall. So discrete breaks can occur at multiple points. It can detach from the pubic symphysis in front. It can detach from the cervix behind. It can detach laterally or tear laterally, or it can tear in a central manner. Now, all these defects may be there separately in isolation or in combination. So one has to make every effort to recognize this and repair the defect wherever it exists. So that is what this picture shows. So if you have a paravaginal, a displacement cystocele or a lateral cystocele, and the pubovesicocervical fascia, which is white color, is torn off the lateral wall, you can repair it vaginally by taking stitches to the white line and reattaching it to the fascia. You can also do a central repair at the same sitting. However, the recommendation is to do these repairs laparoscopically, and the present recommendation for paravaginal repair is to do it laparoscopically, as you can see in this picture. It is represented in this picture. So usually these structures are not so clear as these pictures depict. However, with increasing in experience, one can actually see these structures as discrete structures. Okay, so to put it in gist, I'm using this as a prototype. So how does one repair the anterior vaginal wall? It's called an anterior segment prolapse. It's usually is due to a cystocele. So you can do a paravaginal repair either abdominally or vaginally. You can do a native tissue repair as an anterior colporrhaphy, or if the tissue is so weak, you can reinforce it with a graft. And there are various methods of graft suspension, various types of graft that can be used as already described. Now, if you take away the word cystocele and replace it with the rectocele, you can use the same classification to do various kinds of repair. However, a word of caution, when one uses a graft, particularly a synthetic graft like polypropylene type 1 mesh, there are higher rates of erosion and it is no longer allowed worldwide to use mesh for prolapse repair. However, doing sling surgeries is still allowed and still the best method of dealing with urinary incontinence. Okay, so similarly as the anterior vaginal wall as this picture shows, you can have discrete tears in the fascia. This is a finger in the rectum. And you can see lateral tears, you can see tears which usually detach it from the vault, you can see central tears, you can see inferior tears. The ones I have most commonly seen is a detachment of the rectovaginal fascia from its connection to the cervix, and usually it is sagging down and seen as a U shape in the vagina. So just like in the cystocele repair, you can do a native tissue repair, which is called a posterior colporrhaphy. Wherever you see the defect, you can do a site-specific repair or you can put a prosthesis. However, a word of caution, please do not use prosthesis as a routine. Now, if one wants to restore level 1 support, because level 1 support is the main keystone or rather the cornerstone, because one has to maintain the pericervical supports. If this support is lost, what can you do? This abdominal repairs with mesh is still allowed. Like I said, vaginal repairs with mesh are no longer allowed and can get you into medico-legal suit. But abdominal repairs where you do not enter into the vagina or a stress urinary incontinence sling is still allowed in today's world. So what you can do is take a mesh and attach it to the anterior longitudinal ligament of the sacrum. And this is called a sacral colpopexy. Now this can be done as an open method. This can be done robotically, and which is the easiest, or it can be done laparoscopically. Similarly, instead of just taking the vaginal vault, if one needs to repair and pull up the uterus, it's called a sacral colpohystropexy. So because the mesh extends down into the upper portion of the vagina and it involves the lower part of the uterus, so it's called a sacral hystropexy and it's always done with mesh. Now similarly, you have heard this is again another method of suspending the apex. You can take the vaginal apex and suspend it by sutures to the sacrospinous ligament. Now, this procedure is usually done vaginally. It has its own pros and cons with a slight deviation of the axis, which is not clinically significant. But if the vagina is not long enough, you can always fix a mesh to the vagina and reattach it to the sacrospinous ligament. Now, very often there are many kinds of methods where you can even reattach the cervix. So you can do a sacrospinous hysteropexy. So wherever you suspend the uterus, it's a hysteropexy. Where you suspend the vaginal vault, it's called a colpopexy. Okay, so if the vagina is not long enough, you can take and suspend it to either the coccygeus muscle, which is overlying the sacrospinous ligament, or to the iliococcygeus. However, these are usually salvage procedures and not preferred because the attachment to the muscle can easily tear out and is not a very secure attachment point. A brief word about the Fothergill's hysteropexy, a very common procedure using only native tissue, which was done in the past, and increasingly people are reverting back to this. Now, this is usually offered in lesser degrees of prolapse. So you have an early stage 3 pelvic organ prolapse. The Fothergill surgery may be a good method to do. It is usually associated with the cervical amputation, a reepithelialization of the cervix using the Strumdorf suture, which is shown here, and a reattachment of the transverse cervicals to the cervix, which causes improved support, and this is called a Fothergill stitch. So to put it in short, it is used for lesser degrees of prolapse. It is used where women want to conserve the uterus. It is usually associated with the cervical amputation because there may be a very long cervix. This cervix is again recovered by the Strumdorf switch. And to provide improved attachment, the uterosacral transverse cervical complex is cut from the cervix and reattached at a upper higher point and tightened up. And this is called the Fothergill stitch. Here is another picture showing how to take the Strumdorf suture. Okay, so then comes the next point about slings. Where weaver slings are concerned. Now, if I ask any PG candidate across institutions, including my own, I'll say, what would you like to do to preserve the uterus? They will tell you sling surgery, ma'am. What surgery? Purandre sling, ma'am. Next, tell me one more procedure. Kanna sling, ma'am. Not Kanna sling, Shirodkar sling. Where Purandre is there, Shirodkar is immediately behind. What other methods have you seen which have better results, which are better investigated and are acceptable by through research today? You hardly have any research on your Purandre sling. There are various variations. And these variations go from rectus sheath, attaching the rectus sheath to the uterus to pull it up, by attaching it to the abdominal muscles, by various modifications. But we do not have a series which tells you that this method is consistent. So then the next question I ask is, okay, can you tell me of any other slings? They will tell you composite sling, ma'am, Workwood sling. How often have you seen these procedures being done is my question. So to put it in brief, there's a Purandres, there's the Shirodkas. Very good. Know about this slings when you are discussing an answer. However, the Kanna sling, as propagated by Dr. Piley, a modified Kanna sling with tape, with prosthetic tape, type on polypropylene mesh is providing good results, and I hope we have improved research on this in the future. So a very brief thing about studies, ventrosuspensions to the pectineal ligament, to the lower uterine segment, to the abdominal wall, to the rectus muscle, to the anterior superior iliac spine, multiple methods have been described. However, most of these are very few in number and do not have good long-standing outcomes. So ventrosuspensions is generally not recommended because of its higher failure rate and because it also results in a wrong axis of the uterus and the vagina and a cervical elongation. Coming to obliterative procedures, what is an obliterative procedure? You're obliterating the vagina. So usually recommended in much older women with leaving the uterus in situ to do a short procedure. However, we in our institution usually do a vaginal hysterectomy because I bet you will agree with me that a vaginal hysterectomy takes all of 15 minutes in a postmenopausal woman. So we do it because once you do a partial colpoclasis, as you show Leafords here, there's a strip taken anteriorly, a strip taken posteriorly, and these raw areas are adherent to one another. If there is postmenopausal bleeding, it's very, very difficult to access or investigate. So in a woman who does not have a uterus and she has a post-hysterectomy vault prolapse, you usually denude the vagina, which is called a total colpoclasis, and you can take sutures in a different way all around to totally obliterate the vaginal canal. The lower 1 to 3 centimeters is left behind because this will prevent stress urinary incontinence. I'm not going to detail. The principle is recreate all structural defects, recreate and repair from level 1 to level 3. Make sure you look for discrete defects, repair defects which can either be thinned out or attenuated. You may have complex defects which are both discrete and associated with others. So recreate, the one word is recreate this ring of tissue which is around the cervix. At the vault, one has to be very careful, and if possible, please do a McCall's scaldoplasty with every repair. So this picture is a reinforcement of the previous one. You can see that all these structures have to be tied up at the vault. Don't take thin sutures, take sutures incorporating the underlying fascia. The vagina has to be restored to its axis. And if you're preserving the uterine axis also has to be restored to provide adequate support to prevent a recurrent prolapse. So the management algorithm is briefly as follows. you have a bothersome prolapse, not an asymptomatic prolapse, you can give a pessary trial or an observation with pelvic floor exercises, etc., and lifestyle management. If the pessary is good, continue with the pessary, or you can offer them a surgery, which is a more definitive form of treatment. If she is not sexually active and does not want future sexual activity, consider an obliterative surgery. If the woman would like to preserve sexual capacity, even though she is not sexually active at present, please do not obliterate her vagina. The vaginal approach for pelvic organ prolapse repair is the most popular and the most sensible one because your defects are in the pelvis and easily accessible through the vagina. Healing time is quick, recovery is quick, and you get fantastic results. On the other hand, the abdominal approach is mainly used for hysteropexy or colpopexy and usually augmented with mesh, and this provides level 1 support. So your management should be based on anatomical descent and severity, the organ that is mainly defective, which is prolapsing, urinary, bowel or sexual function, the reproductive need of the person. When I mean GI symptoms, I mean bowel function, of course, and the comorbidities. All these should guide you to decide on what kind of pelvic organ prolapse repair you would like. So this brings me to an end of pelvic organ prolapse. A brief word on urinary incontinence. We very often have this is also pelvic floor dysfunction. We very often have a very simplistic view of urinary incontinence as only stress urinary incontinence. But urinary incontinence, or rather continence, requires an integrated coordinated function. If you take away one thing from this, remember, it's not just anatomy, it's an integrated coordinated function. And we restore anatomy in order to restore function. So similarly, urinary incontinence has very complex feedback loops. Remember, more surgery is not always good. Okay, it is also dependent on anatomical defects in the lower urinary tract and on the pelvic floor. In a normal continent woman at rest and during physical stress, the intraurethral pressure should always be higher than the intravesical pressure. The minute the urethral holding pressure, the closer pressure comes down, she will leak urine. So the various kinds of theories were put forward for urinary incontinence. One is the pressure transmission theory, or also called the Enhorning's theory, where you said, oh, if the organ, the bladder remains in the abdominal cavity, it is affected differently by the pressure versus a sagging bladder. True. The hammock theory, which is also says that the urethra is suspended like a hammock and is sitting on top of the vagina. And the integral theory by Petras et al., which says, look, an anatomic loss of function can result in a physiologic loss of function. So you have to look at it as an integrated body. Often, whether anatomic defects or generalized laxity results in a hypermobile urethra. And there can be discrete breaks in the posterior or the anterior pubourethral ligament. Why is this important to recognize? It's important to recognize because these ligaments provide dynamic support to these organs. It's like a trampoline on which when you jump, the organ is supported. Now, if this trampoline had a defect along the edge or had a tear in the center, the child would fall right through. And this is what happens in stress urinary incontinence. So stress urinary incontinence is the more popular one which we like to address rather than overactive bladder. Depends not just on its anatomical function, its position, the sphincters which keep it attached to the urethra, but also on its mucosa and the watertight seal it can provide, which is why postmenopausal women come with increased stress urinary incontinence because this mucosal seal and the vascular cushion is lost. Okay, so what did the integral theory state or mean? Basically, it says that, look, all these functions are connected to one another. So if I put in a mid-urethral sling, which works like an artificial pubourethral ligament, see how the pubourethral ligament works. And can you see the mid portion of the vagina is the one that is maximally suspended. So it says if I can give in put in a mid-urethral sling, which works like an artificial pubo-urethral ligament, I will provide a backbone of support, and I can do a minimally invasive procedure which provides excellent results versus a birch corpus suspension, which is quite invasive and an abdominal procedure. So what are you trying to provide? Instead of these previous surgeries, which were called colpopexies, which tried to keep a hammock by taking paraurethral sutures and suspending it to various structures, today we have the midurethral sling, which comes out retropubically, which can be brought out through the obturator foramen, which is called the TOT, or the mini sling, which stays within the vagina itself. But the common principle is this all provides a hammock-like support. So this is a V, U, or a head-shaped support. Okay, there are different pros and cons to these different structures. However, we do not have the time to go through it. The other treatments are also bulking agents for women who lose all function of the urethra and it stays wide open. So this is an intrinsic sphincter defect or an artificial urinary sphincter. Similarly, the external anal sphincter, okay, fecal incontinence. The sphincter is usually damaged as the head emerges out of the pelvis during crowning. A 2 centimeter genital hiatus at rest extends to about 11 centimeters during maximum distension with a 9 centimeter fetal head. So imagine in addition to this, you are putting a suction cup or you're using a forceps. What is the extreme distension at the vaginal introitus? So as I said at the very beginning of my talk, if you have a stretch factor of more than 3 times its normal length, it is likely to rupture or tear. Okay, so what happens to this? So let us look at the muscle orientation in the normal vagina. Okay, you can see its orientation, the puborectalis muscle sling, the pubovaginalis muscle. You can see all these are various components of the levator ani and how it provides support. Now look at it, what happens during labor. Okay, so pre-labor and during labor, during ultimate crowning, look at how much the pubovaginal muscle is stretched and how the puborectalis sling is displaced more posteriorly as the head emerges. So what happens? This is a picture which shows you a better depiction. Okay, at crowning, you can see the pubovisceral muscle and you can see the stretch on these various structures and how close it is to the external anal sphincter. So what happens if it stretches beyond a particular point? The levator ani muscle is injured and it is found in 20% of Paris women. I mean vaginally Paris women, there is some form of levator ani muscle injury. And many women do have a perineal body disruption, even though it may not be a complete 3rd degree tear. It is very often unrecognized. So my question would be, think of strategies for prevention and early recognition. A levator ani muscle injury, as you can see here, the levator ani muscle, and you can see here the defect where it is detached from the pubic symphysis. Of course, this is a bilateral defect. It may be a partial defect. It may be a unilateral defect. Can result in very severe support defects, decreased muscle strength, increased vaginal hiatus, pelvic organ prolapse. But there's not enough evidence to link it to stress urinary incontinence, but definitely there's an increased risk of fecal incontinence. So the obstetric anal sphincter injury, much has been said. This can be a major question for you as postgraduates. You need to know the classification of perineal injuries, the 1st, 2nd degree, and of course the 3rd and the 4th degree. The subclassification of 3rd degree into A, B, C is important. But remember that in an incomplete tear like 3A, 3B, what would be done is an end-to-end repair of the sphincter. On the other hand, 3C, which is a complete disruption of the external anal sphincter, or a type 4 injury, which is recognized and repaired on the spot, one can do an overlapping repair. However, when you delay it, you see an old complete perineal tear or an old OAC which is not addressed. As the injury becomes older and older, there's more fibrosis, and very often all one can do is a end-to-end repair. Why is this important? Because they provide equivalent results and one is not better than the other. So the picture shows you partial thickness 3A and 3B. You can do an end-to-end repair. However, in a full thickness tear, an immediate repair can be an overlap. This is just a continuation of the same. What is the role of endoanal ultrasound? Much has been said about it. This shows an external sphincter disruption and the dark line disruption, which is the internal anal sphincter. Very important for prognostication. If you do not have an endoanal ultrasound, can you do a repair of an obstetric anal sphincter injury? Of course. In fact, in most cases, you do not even need it. This is more in research settings and for prognostication and telling the patient how subsequently they can benefit or it can recur. Remember, fecal incontinence, urinary incontinence are not always due to anatomical defects. As you can see here, fecal incontinence can be functional, sphincter weakness, sensory loss. You can see a variety of causes which can cause all this. So please let us not be simplistic. Let us widen the horizons of our mind. Let us understand that it is far more complex than just an anatomical defect with a pelvic organ prolapse, fecal or urinary incontinence. Let us make all efforts to study. Let us make all efforts to recognize, and let us make all efforts to provide the right treatment to provide functional recovery to this woman. So what is important is the quality of life. What is important is a functional recovery. And with this, I thank you for your patient listening. And I'm now happy to take your questions if you have any other. I understand that this is not sufficient to cover the whole range of pelvic floor dysfunction. However, this much only I think is possible. And I think we have done for 1.5 hours. So I'm happy to take your questions. Any questions? I will be happy to address it.
Thank you, ma'am. Thank you so much. It was very exhaustive. It was more like a marathon presentation. From you covered all aspects. Vijaya ma'am, you want to say something, ma'am? Vijaya ma'am, Kiran ma'am?
Hello, yeah, somehow it happened. I was thinking I will not be able to continue, but I was so mesmerizedly, continuously listening it. Very beautiful. Dr. Lily has taken from the basics to the up to the mother connected the basics to the application part, management part. So, and that is what I meant to say in the very beginning, that it looks very simple, but it has a very finer points which are important to be considered when you're considering the management, including the prevention and the restorative part or the treatment part. So it was very nice. Actually, Dr. Lily, that's what I was thinking. Well, my interest was this key, like how you will go out with that, and beautiful diagrams also when you supplemented. I'm sure the students must have got that concept with that, those support of those diagrams. So I'm sure they must be the questions when everybody must have understood are very good. So thank you very much, Dr.
Thank
Lily.
you very much, ma'am. Thank you very much for that encouraging
And
word.
I would again say that I'll send you, I'll personally talk to you again. And if you feel like, then you can definitely join the Urogyne workshop.
Definitely.
This is the part that we have to discuss at the site.
Thank you, ma'am.
Okay.
There's a question in the chat box which says, please demonstrate POPQ. I think that is a whole topic, a 1-hour topic in itself, demonstrating POPQ. I do have videos. I'd be happy to take an extended class anytime. However, as I said, it's very briefly 2 points anteriorly, and I showed you the measurement is from the hymen. I'd be very happy to take an extended class on POPQ. I've done it for the Calicut Medical College. So if you do feel you need it, I'll be happy to take it as a separate class because it's quite large.
Yeah, I understand, Lily, because they, how much ever they read from the book, no, unless and until they see the live demonstration, they won't be very much convinced. That is the thing, but that's okay. But then this point, anterior and posterior, it's all the measurement, no, that is very important. Where to measure? From the hymen, where is the hymen? That is they are confused with that.
Yes, ma'am. That's why I showed the picture, ma'am. Ma'am, the other thing is we are doing a PG study. One of my PG candidates, we are doing, instead of using a measurement device, etc. Very often, even by looking at it, we know it's 1 centimeter outside, 2 centimeters. So even just looking, eyeballing and writing approximately is enough. Or we use a finger. So we did a PG thesis on how to use your finger, how to measure your finger and do it instead of a device, because your finger is equally available at all times with you. So maybe we can do a publication sometime later. We have done a study. But I would encourage everybody to start using it. You will make mistakes at first, but put the 3x3 PopQ grid, draw a diagram. I can show you all this if you have a further class on PopQ.
Definitely, before we close this section series, that will be a add-on bonus for the.
Yes.
There's one more question, ma'am. Ma'am, Dr. Pavitra has asked, is uroflowmetry necessary for SUI cases before doing TVT or TOT?
Okay, so there is something I would like to, sensitize you to the fact there's something called an index case and something called a complicated case. So in an uncomplicated stress urinary incontinence, okay, which you have to investigate, okay, you don't need a Euroflow machine. If I may say so, I can say, why don't you do a pre-void and a post-voidal residue? Even on ultrasound, you can do it. Okay, so you do not need a uroflowmetry machine. Do a pre-void and a post-void residue. Check whether it is mobility. Look at the anterior vaginal wall. If it is hypermobility, there are no other risk factors, no previous surgeries, no diabetes, nothing else that makes you suspect a neurological element to it. There is no need to do a uroflowmetry or an advanced urodynamics, which is a multi-channel cystometry. But at the minimum, image the urinary tract. Look at the bladder, look at the kidney for hydroureteronephrosis. You check the pre-void and the post-void residue. So simple cases, bottom line, no need. But however, make sure it is a simple, straightforward case, the first case that you're doing. On the other hand, if it is a repeat case, if there's a failure, there's mesh erosion, there are medical complications, the previous pelvic prolapse surgery, then you may need to do at the minimum a uroflowmetry, if not a full urodynamics.
Yeah, in one of your slides, there was a mesh for the anterior support. Is it still advisable?
No, ma'am, no, it's not. I just put it there for teaching purpose to tell this was one of the options. However, see, Dr. Piley and group say that they have excellent results. Personally speaking, ma'am, Dr. Piley is a wonderful surgeon. He's got hands of gold. But in the ordinary PG, the message to the PG is do not use a vaginal mesh because you're introducing it through a potentially infected area. Mesh erosion rates are high. And when you have a mesh sitting there, it causes a lot of fibrosis, even though your mesh may be soft, and this can result in dyspareunia. Now, if you have a case, a medical legal case that comes across, you will have no leg to stand on. So you cannot support or defend yourself. And if you have seen cases of erosion and dyspareunia, it is so horrible. It is so horrible. So do what you would do for your daughter, for your mother, or for yourself, what you would want for yourself or your patient. I would encourage each and every one of you to look at the tissue. You can see the difference in color tones. You can see fascia. You can see defects. You can do a site-specific repair. We get wonderful results with facial repair. And use PDS. Use PDS if you want to do the repair. It works like a meshwork and also it disappears. Polydioxone. Polydioxone.
Number 1.
20, ma'am.
20 PDS. Okay.
PDS. But if it is Vicryl, polyglactin, we can use one. The needle is beautiful on a number 1 or 10 suture. The needle is way more flimsy on a 20 suture. So if it is a polyglactin, you can use a 10. But however, PDS becomes much more pokey and stiffer. So we use a 2-0. Nowadays, I routinely use 2-0 PDS for cystocele and rectocele repairs, madam.
What about high uterosacral suspension?
Madam, personally, I know Dr. Uma Devi Swain is very good at it, but I would advise a word of caution. I'd like to, if I want to do a uterosacral, I'll do a laparoscopy and I'll trace the uterosacrals all the way back, separate the ureter from the lateral side and do a plication and a fixation because I know I have the uterosacrals and I can use a permanent suture. I have done it on occasion 1 or 2 years back. I have done 2 or 3 cases of high uterosacral vaginal suspension and 2 times the ureter kinked, even though I didn't have a ureteric injury. And I've had to remove the suture and restore it. So, and it is a well-known complication that you can have kinking of the ureter when you do a vaginal procedure. So maybe not as a beginner as you become more and more advanced. Personally speaking, I would like to do a high uterosacral laparoscopically because I can see all the structures and make sure that I'm not injuring it.
Yeah, small point on pessaries. How often they have to change? How do they clean it? Whether they autoclave it or disposable? Because these are the questions they ask in the ward rounds. So can you highlight?
Yes, ma'am. Ma'am, I usually use a silicone pessary. Their companies, I forget the company name now, but we get it from Chennai only. We get silicone pessaries, and we use pessaries quite often. And what I would advise, especially younger sexually active women, I would tell them during the morning you put in the pessary if they're agile. These are all personal recommendations. Take it out at night when you are sleeping and when you can keep it reduced for lesser degrees. Second thing, it may also interfere with sexual intercourse. So if the woman is sexually active, I tell her take it out. If it is troubling you during sexual intercourse, wash it, dry it, keep it in a separate place, allow it to dry, keep a separate box, clean it. There's no need to autoclave, no need to boil it because it spoils the structure. Just wash it, dry it thoroughly, make sure there's no infection. So at least once a week, I would advise most women to take it out because vaginal discharge can increase. Many sexually active women, I tell them take it out at night if you do need sexual activity. On the other hand, in a less active woman who's more debilitated or who, you can leave it in for 3 months with some vaginal estrogen cream, but she should have a good pelvic flow and ask them to come at least once in 3 months to the hospital to remove it, clean it, inspect the vagina, make sure there are no ulcerations and reinsert it. Also, we use each one of these opportunities to reinforce how to use a pessary with a woman.
Yeah, good.
We do offer it, ma'am, especially for the healing of decubitus ulcers. I have 1 or 2 younger patients who are using it long term. However, some women say, no, I'm tired of this. I don't like handling my own genitals. And then we offer them definitive procedures.
So this is very important, no? It's
So
a
the-
ring pessary, is it?
Yes, ma'am, ring pessary. The other pessaries with the stem, etc., I am a little, see, we don't get it easily. Second thing is, you want to make sure there's nothing poking into the rectum or the bladder.
True.
So definitely we use a ring pessary. There is something called a ring pessary with a bolster in front for urinary incontinence. But many women may have to remove those kind of pessaries once they are after the exercising. We used to get those pessaries, ma'am, but I don't find the uptake very good. I prefer a ring pessary and a
Yeah.
silicone one.
So, and doubt, ma'am, these these women, they insert the pessaries themselves.
Excellently, beautifully. Just try it and see. We
Yeah,
make
how
them,
to use a menstrual cup they using.
yes, if they're using a menstrual cup, why not? And we ask them to bring a little mirror.
Ah,
And we insert it first, showing the mirror. I insert it. Then
ah,
I make them hold the pessary, constrict
easy.
it, put it vertically, turn it horizontally, and push it into the funnel. They pick up very fast. Second thing is, ma'am, I make them walk around for some time
Right.
and make sure that they do not have urinary obstruction. And many of them are quite happy to handle it. And it costs about 1,500, 3,000 rupees. Many women are quite okay with that.
Yeah, pessaries are actually quite cheap.
Otherwise, our hospital provides it free of cost for some women who really require it.
And I have a couple of questions, madam. So for vault prolapse, so what is your treatment of choice?
Post-hysterectomy vault prolapse.
Yeah.
If I have a person who's sexually active, definitely I treat all of them with vaginal estrogen cream, especially because if it's an older woman, it makes it much more supple. Second thing is I would do a pelvic floor repair and a sacrospinous fixation unilateral.
Okay.
In all cases, if the woman does not want sexual activity, she is not interested. Many of them say, my husband is sick, I've not been active for many years. I will do a colpoplesis
Okay.
with a hypocorpoperinorrhaphy.
Why sacrocolpopexy?
Why not sacral colpopexy, ma'am? And it's a much more complicated procedure one.
Yeah.
It is easier to do robotically rather than laparoscopically, which limits your movement. Second thing is, many women, if you are doing it along with the hysterectomy, your erosion rates are higher. If it is a vault prolapse, I have seen people in Kerala just put a small strip of mesh anteriorly and fix it to the pectineal ligament. However, they're pulling it up anteriorly and they do all these cases robotically. So I would say, yes, put a mesh where it is indicated. If your primary vault prolapse surgery has failed, like you do a sacrospinous fixation and it has failed, then maybe consider mesh and consider an abdominal mesh. But I am very, very cautious about using mesh because it is not the body tissue. And once it starts giving trouble, the trouble can be major issues because we've removed mesh from so many women who have had erosions.
So you fix the wall to the sacrospinous ligament.
Yes,
Not
I fix the vault.
the proline.
Yeah, no, we can use Proline or I even use PDS. If we use PDS, we take it through and through the vault and tie the knots in the vagina. If we use Proline, we use it as a pulley stitch.
So for SUI, madam, you are using TVT or TVTO? Which one do
See,
you?
again, I'm quite cautious. We have done few autologous slings also. Okay, rectus fascia sling and fascia lata sling. But by and large, only after significant physiotherapy, if they have significant prolapse, do we even offer them a mid-urethral sling. Mainly TOT because it does not require a cystoscopy. However, if the woman has significant leakage, with even minimal movement, I would offer a tension-free vaginal tape retropubic.
Okay.
But your chance of injury of the bladder wall is higher and you definitely need a cystoscopy following a TVT. A TVTO does not require. Transobturator does not require a cystoscopy.
Okay.
And about this laparoscopic Birch colpo suspensions, what is your take on these things, madam?
Dr. Kalpagamal, I have done open birch. It is essentially what you're doing is again creating a hammock-like structure.
True.
And the original birch tied it up tight to the ligaments. Now the Tanago, what you call modification, leaves a 1 centimeter suture. It leaves a loose suture. You are going through a very vascular area. And I do not think much. I have not done it laparoscopically. 3 or 4 times I've done it abdominally when we've had another associated abdominal procedure. And many of these patients have not come back for follow-up. So personally speaking, I don't have a very good experience to really recommend it, while a more minimally invasive autologous sling or a mid-urethral synthetic sling is available.
That's what if we given laparoscopic or Birch colpo suspension on one hand and TVT or TVT on the other hand, which one would you choose? I thought.
Okay, definitely mid-urethral sling.
What about the pectopexy, the new surgery?
Yes, ma'am. The pectopexy, like I said, ma'am, you can take and fix anything to any structure which is firm enough. So people have used the anterior superior iliac line, that thing for kanna sling. I've used it. I've done quite a few kannas and it's good results. Then people have used the pectineal ligament. That's the lacunar ligament. They've used the sacrospinous ligament, any firm structure. But when on the whole, ventral suspensions can open up the pouch of Douglas to recurrent prolapse. So it should be done with a Moskowitz or a Hallbenz. You have to close off that area because you're changing the axis of the vagina. So, and I have seen people, particularly in Kerala, put a lot of mesh on the top of the vault and fix it to the pectineal ligament.
That's a pectopexy.
Yeah, pectopexy. So personally speaking, it is quite easy to do, but I'm not sure I would put mesh at the first go, even though it may be very easily recommended by some.
From the
Yeah.
fundus of the uterus to the pectineal ligament, or
No, man, from the pectineal ligament to the, if you're preserving a hysteropexy, the attachment should always be, the mesh should be at the level of the isthmus posteriorly.
Yeah.
Posteriorly and not anteriorly. Because a posterior attachment, even in a kanna sling, actually promotes anteversion. But if you are doing it, particularly a pectopexy, I would hesitate, because as the uterus enlarges with pregnancy, the fundus should be free to enlarge. The lower uterine segment should be free for a cesarean section. So putting any kind of mesh anteriorly in the lower uterine segment or the isthmus when you're non-pregnant would prevent a cesarean section, which can become more dangerous, or you will cut the supports, or you will prevent an expansion of the fundus of the uterus, which is the primary aim of the uterus after all in a pregnancy.
Retaining it.
in
Yeah.
kanna sling, you'd use the proline or mesh?
I use type 1 proline, ma'am. You use a strip of proline, you attach it to the back, but you have to make tunnel between the broad ligament.
Then go
Approach the posterior level of the isthmus. It is quite easy to fix it the way doctor, and even you can see the ureter under your eyes. You will not have ureteric injury. Then provides very good level 1 support.
it is iliac spine, it is easy to poke.
Yes, it's not very difficult, man. You can just extend the incision a little and you can see the nice white color line. You can actually see it there.
Promontory, like that.
Yeah.
Okay.
One last question, madam.
No problem.
No. See, there are a lot of vaginal tightening procedures that are really coming up in a big way for this, like pelvic floor dysfunction.
Yeah.
What is your take on these things, madam?
See, personally, I am less of a cosmetic person than a curative person. I know many of these lasers help in thickening the vagina. Okay, providing more collagen because it stimulates. It's like a laser on your face if you
Yeah.
are doing it for rejuvenation. But to what extent that will improve an underlying muscle, I don't think, because its penetration is only up to the vaginal thickness. Definitely in genitourinary syndrome or menopause, in sexual function, it may help by causing a thickening and an increased thickening and a rejuvenation. But stress urinary incontinence, I think the evidence is a little iffy out there. So, because it does not really restore.
Anatomically, it does not serve the purpose actually.
It doesn't, because it does not provide a backbone of support like a hammock, nor does it provide an increase. So a vaginal estrogen cream will improve the hermetic seal, or what you call the watertight seal, the vascularity. But laser by itself or a rejuvenation technique may help with sexual activity, genitourinary syndrome of menopause, burning, discomfort, all those things. Whatever is limited to the epithelium, I'm not very sure about the rest, man.
Okay, thank you. Thank you so much, madam.
Kiran, you want
you.
something?
And another thing, I think this laser part also have to be done, if I'm not wrong. I am also not a cosmetic person. 6 monthly, or I mean, it has to be done repeatedly. It's not a one-time procedure which will, even in any function. Only thing, maybe one time might help into increasing the confidence of the patient, like a sexual dysfunction. Once it is improved, this gives the confidence and continue. Otherwise, as far as I know, 6 monthly or whatever time one can give the good, depending on the laser, it has to be repeated also.
We need more
Yes,
evidence.
ma'am, I
We
agree.
still need more evidence to get into
Yeah, definitely. But I have one good experience into like apical, abdominal colpopexy, and even abdominal sacrocolpohysteropexy. I have done many because sometimes patient comes in a very bad state, and so that part is good. Sacrospinous, I have always found little cumbersome. The space is not so open. So exactly, always feel you a little bit of pudendal nerves and arteries. You are scared. And have you, Dr. Lily, have you used you take those needles, or you use guns these days, which are being.
Okay. See, ma'am, what I would say is I am a basic pelvic surgeon and I love pelvic surgery. And of course, as you said, for hystropexy, you do a hystocolpopexy. I've done quite a few. It provides more sustained results because you're using a mesh. But for particularly a colpopexy, I always expose it. I see it under vision, direct vision, and I just use a curved Mayo needle with a long needle holder. I don't use any specific device like a KPO capture device or any device.
Yeah.
I don't even hold it with an Alice because you can see it and you can get the feel of it as you're moving your Mayo needle through it. And we've done quite a lot, madam. And I found that the results are quite good and quite sustained, provided we do a good native tissue repair along with it. So yes, it also depends upon your skill and over
And how
time,
many you have done over
how many
time,
and how comfortable you are with the procedure.
Yeah.
So
These
what
days,
is good?
actually, people are using guns, so I had no experience. So I thought, maybe
Well, the
like
KPO gun device requires a specialized needle because it has to transfer from limb to limb. Second thing is, actually what you need, you can feel the ischial spine because for us, everything is ischial spine as obstetricians. Everything is at the ischial spine. So when we feel the ischial spine, you just need 1 to 2 centimeter clearance, keep the rectum away. And yeah, it is a little deep, man. And very rarely, unless you go so close to the ischial spine, you will not hit it. It's all of 4 centimeters. The mid portion of the thing works beautifully. I just use a plain Mayo needle, man. I just use a plain Mayo needle with a needle. I'm always afraid that's a part of my nature to become too dependent on technology because if technology fails, you failed completely. So for
and
me,
I can assure, I think you have been, Dr. Rajalakshmi has come, Raja Maheshwari has come to the Kanpur also. So I know she is very fond of the sacrospinous. In fact, 2015, she came to Kanpur in a Urogyne workshop. And from then only I started doing the sacrospinous.
Yeah.
So
We all
before
learn
that,
from
I was not doing it.
all repairs. We'll all learn from Maheshwari ma'am. Cystosil,
Yeah.
we were so.
And she's passionate. She's very passionate about it. That repair part is very important, and I mean, teaches very important points.
Closed down, I think.
yes, ma'am.
Yeah, thank you so much. Thanks a million, Lily ma'am. Thanks.
Ma'am, it's a joy. It's a joy to always share and to hear others' opinions. It just opens up your mind. Thank you so much. All
Thanks.
of you.
And see, I told you I will not be able to remain, but I was throughout with
Thank you, ma'am.
Thank you so much for joining from
Thank you,
there,
ma'am.
Kiran ma'am. Thank you all the participants. It was really nice
I
because
can see Dr. Dhanam also.
and Dhanalakshmi ma'am is on. Ma'am, good evening, ma'am. So thank you so much everyone for participation because it's just we share our knowledge and we actually learn more. Ultimately, feel like fine, okay, there are a lot of ups and downs, a lot of ifs and buts, but still, ultimately, we are very happy learning and sharing the knowledge. Thank you so much, Lily ma'am, for this excellent presentation. And I'm sure
Anytime.
all the postgraduates would have been really benefited, and they're all exam going now. And thank you so much. And Kiran ma'am, Vijaya ma'am, our president, Vijaya ma'am, Dhanalakshmi ma'am, all the executive committee members, all the participants, thank you so much for participating, and wish you all all the very best for your forthcoming exams. And I also thank Shield for this platform because every time we are very happy to have them as the platform for our webinars. And great going. The 8th webinar is over and we'll look forward to many more. Thank you so much for your
Very well. Congratulations.
Thank you.
Thank you very
Thank you
much,
very
ma'am.
much.
Thank
I
you
will
for your
leave now. Good night.